Can everyone see my slides?
Yes, yes, we can.
Okay. All right. Thank you. So this is where I work in Hull. It's the Yorkshire region. Uh, it's in the north of England. There's a little garden here. When the weather is good, we come out here to have some rest. So I will hopefully go through this um, outline and, and discuss some new stuff if we are interested about that. So let's look at the aorta first. It's just this big tube that connects the left ventricle to the whole body. So if you can see my cursor, you go down here where the aortic valve lies, and this complex from this sinotubular junction to the annulus here is what we call the aortic root. So the root contains the annulus, the valve leaflets, the sinus of valsalva, and the sinotubular junction. Then it goes like a cylindrical tube all the way down to the groins. And in the head and neck here, we have the arch vessels, and just before the brachiocephalic artery here, and after the subclavian artery on the left side here, that is the aortic arch. And just beyond the left subclavian artery, down to the diaphragm, the descending thoracic aorta, and below diaphragm is the abdominal aorta, till it bifurcates into the iliac vessels. In recent times now, it depends on where you walk around the world, the purview of the cardiac surgeon is nearly limited to just from the subclavian down to the aortic root. This area is a mission can be dealt with in endovascular stenting nowadays. This may not be available in every country, so cardiac surgeons may still deal with this via open procedures. In some cases, you may still require open procedures, even in advanced centers. So, what are the common diseases that could affect the aorta? The common ones I'll discuss here is aneurysms, when the aorta becomes enlarged beyond its normal expected size for age and sex, or what we call the acute aortic syndromes, which are the emergent presentations of aortic diseases. Other conditions could be inflammatory or congenital, but what surgeons will mostly deal with is the aneurysms, the acute aortic syndromes, and some congenital conditions. So as surgeons, what we see mostly in the order how we see them, I'll put this way, or in the order how it's more significant, if I put it that way, is the acute aortic syndromes. These are things you need to identify and manage as an emergency. Then we have the aneurysms, which we can manage electively on the cold light of day, and the coarctations, which is seen commonly in children or missed in adults. So if I just go through quickly, what do we mean by acute aortic syndromes? So the aorta, if you have a histology of the aortic wall, if you see my cursor, this is the lumen, this is where blood flows, which is always nice. This intact yellow layer here is the intima, the tunica intima, tiny layer, endothelial layer. And this area we have muscle fibers is the media, tunica media, and the external one is the adventitia. So these all parts of the normal aorta. However, in a dissection, there has been a rupture of this intima, and blood is flowing from the lumen of the aorta into the tunica media, creating eventually two lumens. So blood will flow here, which we regard as a true lumen, and blood will also flow here, which we regard as now the false lumen. And these are what leads to the consequence of what dissection really leads to, and why it's quite urgent to treat this patient. Otherwise, they'll have end organ malfunction and possibly die. The intramural hematoma. So, if you have muscle fibers, we also have blood supplies to these muscles. Most common blood supply, what we call the vasa vasorum. These small blood vessels could rupture, And when they rupture, they could lead to bleeding into the tunica media. And this patient may present with pain. Because why do they have pain? Because stretching. Because when there's bleeding here, this space in the media expands and stretches the adventitia. The adventitia contains the pain fibers that we now perceive as pain, as central chest pain. We know that most of patients with these or these are in evolution. So you can have a vessel ruptured here, you have bleeding into the media, and it could eventually rupture into the little lumen, and you have like a dissection. So it could be an evolution. And that's why we manage these patients similarly to a dissection. And lastly, here is the PAU, or the penetrating atherosclerotic ulcer. So these are patients chronic patients with atherosclerosis, very calcified vessels. And what happens is that this calcium around the vessels, because they're not really expansile, as we know, they're not really smooth muscle, they're calcium. With hypertension, this could also rupture and easily blood flows into the media and forms a kind of a protrusion, like a swelling around the adventitia there. And we'll see them in patients mostly common in the arch, and we'll discuss how to manage them in the next following slides. So I'll start with aortic dissection, which is, I would say, the thing everyone in A&E, every doctor should be aware, and this is a condition. We'll discuss this pathophysiology already. It's just a tear within the intima. And so if it has a tear, there's an entry point. This word entry point is very important in the management of this patient. The word also false lumen is very important in the management of this patient. So we need to keep this in our minds. They could be acute, chronic, or subacute. So if a patient presents within the first 2 weeks, we tend to call them as acute aortic dissection, and we treat them as such. If they present, maybe someone comes for a scan for something else, and they said, "Oh, 2 months ago I had some pain, but you went to it after 5 days," and you do a scan and you find a dissection from the scan, like, oh boy, yes, that's a chronic dissection now because it's beyond 2 weeks. So we call it after 2 months, it's chronic dissection. Between 2 weeks and 2 months, we can call it subacute, and the management varies slightly. Now, there's what we call type A and type B, which I will show in the next slide. So just to say, type A here is the most significant of the acute aortic syndromes. So why is dissection significant? Because it has a high mortality rate. 30% of patients who has a dissection will die at site. So if we have 100 people having dissection, 30 of them will have died at site. They won't get to hospital. Now, when they get hospital, their mortality rate increases 1% per surgery. The mortality rate is going to increase. So if something today to 24% is added to the percentage pre-presentation. So it goes higher and higher. Now, one of the earliest description of someone who had under dissection, surprisingly, was in England, King George II. So, well, said he was training in toilets. I don't know why, and he screamed and died. The doctor saw him and had the autopsy, and they found that he had a ruptured aorta and blood in his pericardium. So he had a tamponade from the bleeding into his pericardium. And then that's when people started looking at what is this about, why is this, and I started thinking about what could have caused this. Before we go further, I must give credit to the two people who really pushed, not really aortic dissection, but cardiac surgery in general in this century. From Texas, Heart Institute. I'm sure we've heard some stories about these two gentlemen who are remarkable surgeons who had their own differences, a bit of, I won't say conflict, but I think they pushed each other and they really changed the barrier, they moved the barrier for surgery. And that is Denton Cooley, who is a gentleman here on the right, who passed away following that dissection. He had dissection too, had surgery at 90 years of age and died afterwards. And Michael DeBakey also is two gentlemen working in Texas and really pushed these frontiers. So how do we classify dissections? So there are two classifications: Stanford, which is very easy, and DeBakey. So you can, whatever you choose, but most people will just Stanford quickly these days because it's quite easy to understand. So what's a Stanford aortic dissection? Is any dissection that involves the ascending aorta or the arch. type A. Simple. And when you say involve, what does that mean? Involve means the entry tear. So the entry tear with this arrow here, so blood leaks from here into the ascending aorta, from the ascending aorta into this intracranial media, and makes a false lumen. And this false lumen can be limited only to here and stop there, or can go all the way down to the groin. So once the entry point is in the ascending aorta, that's a type A dissection. So ascending arch. However, if the entry tear is beyond the ascending aorta and is here, then it's a type B dissection. There is another classification called a non-A, non-B. So when you have an entry tear somewhere around here, and the hematoma is retrograde to the ascending, sometimes it's difficult to tell where does it start from, because this entry tear may not be very clear on the CT scans or imaging you've done. So say a non-B, or if a tear is just here. So because what it means is that you cannot manage it like a typical type A, and you cannot manage it like a typical type B. So you could have non-A, non-B. But if this classification is good, because for the exams or any test, they will ask you these questions, type A dissection on the CT scan, you do, or you produce the answers as appropriate. If you understand the DBAKI 1, 2, 3, 4, and 5, even better. You can study about them too. Now, what are these factors to develop a dissection? I put them in capitals: is hypertension, hypertension, hypertension. Most of the patients who have a dissection are actually hypertensive. And when they present to hospital, they are even more hypertensive. So it's like a vicious cycle, because they have chest pain, the rupture into their tunica media, their end organs are now not getting enough blood, because when blood goes to the false lumen, it could compress the vessels supplying the kidneys, the liver, the gut. And when the kidneys don't get enough blood, it releases the hormones and it goes to synthesize to stimulate more increased blood pressure to get blood supply to itself. And the cycle continues that way. So hypertension must be controlled in this patient, and it's a risk factor for dissection. The next common is the connective tissue disorders, which the most common is the Marfan's, Fibula-1 gene. These patients are special, if I put it that way, because the way we manage them is a bit different from patients who are non-syndromic dissections. Same thing with Turner syndrome and Ehlers-Danlos syndrome. Most patients will have atherosclerosis. Some patients may have an existing aneurysm, which no one has seen before or is known. And that aneurysm, because it's an enlargement of the wall of the aorta, that enlarged wall is abnormal and weakened. So with increased shear stress, that abnormal wall can fracture. And when it fractures, that means breaking the intima, blood can flow into the media, and that's a dissection. Bicuspid aortic valve, we know that if patients with aortic valve, normal aortic valve, have 3 leaflets, when they have 2, that's a bicuspid aortic valve. Because the flow dynamics through the valve, they are associated with a enlargement of the ascending aorta, and that causes weakening the wall, and they can also have a dissection. The last two, iatrogenic is very common. Well, it's not very common, but it can happen in theater when you are operating on the heart for something else, and you're cannulating the aorta, putting the cardiopulmonary cannula. You could tear the aorta and it could leak into the media and have a dissection on table. Or if you're in a cath lab doing some stenting in the coronary arteries or doing any procedure in the aorta to get to wires, this wire, a bleeding can occur, and next thing you have a same thing with also with trauma to the same mechanisms. And how they present with sudden tearing chest pain and radiates to the back. Now, there are many conditions that present with chest pain. The first common one, if anyone comes to A&E with chest pain, is myocardial infarction. So myocardial infarction and dissection are always intertwined. Many patients will go to the cath lab first for stenting or have troponin sent. And when all these are negative, people start thinking about a dissection. So we always tend to advocate that if a patient is coming with chest pain, do not only think about myocardial infarction, also think about a dissection. So if you can get a quick on-table ultrasound scan, or if the history doesn't suggest, if ECG is normal, then quickly think about dissection and get a CT scan if possible. And chronic dissections, as I said earlier, mostly are incidental findings on CT scans. Now, patients with dissection will have a conundrum of problems. One of them may become the stroke. So you have chest pain and say, I just feel weak in one side of my body. And why is this? Because one of the arch vessels has been involved in dissection, so blood is not flowing through the correct pathway. Maybe more blood is in the first lumen than true lumen. And when the true lumen is obstructed, the patient have a stroke. Or if the coronary arteries, which attach to the sinuses of Valsalva, the first lumen can actually compress the coronary artery or even shave them off, or they could dissect it off the aorta themselves, and you have an MI. Sadly, patients who have myocardial infarction following a dissection may not make it to hospital because they will die of acute myocardial infarction and the heart is gone. Some may present with hemopericardium, so there will be blood around the pericardium. So that's already like a, let me say, I'll say sometimes we treat them as a contained rupture without dissection. And they're quite very important to know. If you have that, you have to plan your strategy in theaters of how to approach the patient. The valve leaflets could be prolapsed because the valve leaflets align on the intima on the in the sinuses of Valsalva. If that intima is ruptured or there's hematoma, the leaflets will lose their tone and lose their attachment to the aortic wall, and they will prolapse and leads to acute aortic regurgitation. Because the heart is not prepared for this, compared to patients who have just normal AR from chronic disease, there will be an acute decomposition of that patient and acute heart failure, pulmonary edema, patient is very poorly, and this patient will require urgent care. You can also have any organ ischemia in the upper limb, no pulses in the lower limbs. You may have abdominal pain from abdominal ischemia or the renal function. So when you do a CT scan, you find that one kidney does not show up on the CT scan while the other kidney show up because no contrast is getting there, because there's no blood supply to that kidney. So you know each patient may need to go on may need dialysis in the future if both kidneys are gone. And same thing for paraplegia. Patients who have dissection and extend to the arch, especially going up to the level of the subclavian artery, they could have the arteries to the spine shelved off, and they have spinal occlusion and have paraplegia. Now, how do we investigate patients with a dissection? Nowadays, the most easy, well, I would say easy to do, quick to do, available maybe in most centers would be a CT scan. Because there's no observer dependency on this. Go to a CT scan, it's easy to use, it's reliable. You can do it by the bedside though. You can do it for serial imaging. It shows the aorta very well. And though it has its radiation risk, yes, and it's also contrast is given, and kidneys don't like contrast, but this is the most imaging people do. The next common, I would say, will be TO or TTE or TO echocardiogram, which are of them. Now, the echo will only show you up to the ascending, so the root and ascending aorta. So if you see a flap down the T on the OE, which we do in esophageal echocardiography, which we do in theaters, can show us ascending aorta too. So if you're on table and you think you have a dissection, then be helpful because you cannot go to CT scan at the time. So a patient who is unstable to go to CT scan, then echo can be of use to make an impression of this dissection. MRI, better for follow-up of patients because they're less contrast, and if patient is young or female or mostly young patients, because you need scans every year and follow-up, so you meant to MRI because to reduce their radiation risk. I'll show you some guidelines. This thing you see here, guidelines from the European Society. So these are European guidelines. Just once in a while you see these slides, and these are guidelines showing the class of recommendation of this information. And one thing we said here about the imaging is that if you've started with a CT scan, it's best to use a CT scan again next time because each test have a bit of intervariability. So if you use same scan all the time, and it's better to trick, and that way you can get appropriate measurements in doing follow-up. So patients with dissection, if you manage medically, most will die in hospital. If you do surgery, so this is high risk, and it's about 20% mortality rate of surgery. So it's high risk surgery, but you better chance of surviving with surgery than medical therapy. And how the patient die? Either the aorta burst and ruptures. Those guys don't make the hospital. They're down on the scene, or they have cardiac tamponade. They commit to hospital with CPR or acute MI. If it's the MI is on the LAD area, as the anterior descending artery, they may not make it. But if on the right coronary artery, they could make it to hospital. If they have a stroke, yeah, stroke does not contraindicate for surgery, so you can still give them surgery, and they could be in cardiogenic shock from severe aortic regurgitation. So when you get a phone call of a patient in A&E with chest pain and you think it's a dissection from the scans, one of the things you do is to ensure that blood pressure is controlled. Do not transfer patients with hypertension, because the medical team may not understand this, so you need to get that information. Blood pressure is under control, because if blood pressure is very high, it just propagates dissection and worsens the patient every minute and every hour. With good blood pressure control, the extent of dissection or the progression of dissection is reduced. And we recommend the labetalol infusion, which is a beta blocker, to be started in every patient being transferred with the dissection to hospital before surgery. So even the patient is in your center before surgery, the few hours while you're preparing theater and preparing your team, commence on labetalol infusion if blood pressure is high, to reduce the shear stress on the aortic wall and also reduce the blood pressure. And urgent surgery is recommended for everyone with type A dissection. So type A, urgent surgery. Patient with type B, if you have a type B dissection and is let's say uncomplicated, so it's not ruptured, there's no leak, there's no pleural effusion, I think it's blood, you can treat them medically. So medically, treatment of type B dissection that's beyond the left subclavian is blood pressure medication. So we do the blood pressure control and do serial scans. And then you can now plan for a elective procedure, which is mostly a TIVA, so it's a stenting through your groin for this patient. A few patients who have mild perfusion, which will be a type A dissection, then you may have to do a hybrid approach. So you might need to first treat the mild perfusion if possible. This can be done with your colleagues in the interventional radiology to guide wires to perforate the fourth lumen to allow flow in two lumen. It's a quite complex procedures. Or you can do some deep branching procedures to provide blood supply to the organ that is ischemic before you go for surgery. Because surgery takes few hours, 5 hours in theater, sometimes more. The longer you're in theater doing surgery, that organ is suffering more ischemia. The organ will not recover after the surgery. So what are the principles of surgery in patient with dissection? First, you need to understand the extent of dissection. What am I going to do in theater? How much will I take out? How much will remain? Will the aortic root be replaced? So that's the valve and Santa Valsalva. Would I need to do the arch also? This thinking will guide you on how whether you need to clamp the aorta, not clamp the aorta, or you need to cool the patient down and do a circulatory arrest. So you need to view your scans well with a colleague if possible, just to make a plan of what to do. But once you embark on the procedure itself, you don't want to vary too much from your plan, otherwise you just will have confusion and catastrophe. You need to also plan your cannulation strategy. Cannulation means putting the way you put your pipes for bypass. Your groin, which will be femoral cannulation, femoral artery, femoral vein. You cannulate the axillary artery and the aorta, or axillary and the right atrium, or axillary artery and the femoral artery. Or you can cannulate centrally, which will be the aorta beyond the dissection and the right side of the heart. Most people will cool patient now, but may not go circulatory arrest, but may cool patient down to 24, 25 degrees. And so it's best to start cooling. Cooling gives you some protection to end organs. So you don't have to be, you can, in case you intend to do catastrophe, you're already in a safe area to manage the situation quickly, even if you have to do a short circulatory arrest to fix the catastrophe you encountered. You need to think about how you protect the heart. Myocardial protection, which will be either giving cardioplegia to the root, to the direct coronary cardioplegia, or retrograde cardioplegia. Patient with aortic incompetence, you think about venting into vent the left ventricle to prevent left ventricular distension that will lead to myocardial necrosis, and that heart will not recover after bypass. Or we think of a team approach, so you need to discuss your plan with your surgical team, anesthetists, the vascular surgical team on call, interventional radiology team on call in case you need their help for some device or endovascular approaches to treat this condition. In theater, we try to monitor them with dual arterial lines, so one arterial line on the left side of the body and on the right side of the body. Because we know the right side of the body, you have the brachiocephalic, left side of the body is the arch, descending arch, and the left subclavian. So if you want to make sure, if you're going to clamp the aorta or something in the arch, you need to know that the blood supply is to the right side and brain is fine, and left side is fine, which is the end organs down. Central bypass, fem, axillary, something they call samurai. That's mostly for the patient on table, post-induction, just crashes or collapses or blood pressure goes down. You just need to samurai, just like you cut into the aorta, put the cannula and go on bypass. It's quite dramatic, but if you used to it, it's very simple. Some of the principles which I will discuss later, just mention them here. You must make sure you excise the anterior chair. So the anterior tear is the ascending aorta, you need to excise the anterior tear. Otherwise, if you don't excise the anterior tear and you just replace whatever you replace, blood will still flow to the anterior tear. And that will still be a dissection because the main thing is blood flowing to the abnormal channel and causing that expansion of abnormal pathway, which most times compresses the normal pathways. And you need to think about if you're going to replace the valve or repair the valve. And we advocate these days for an open distal anastomosis because the layers are, you can actually see the layers very well. They're not damaged by the cross clamp, and the recurrence of aneurysms around that area is less. The first aim for surgery in dissection is to save the patient's life. Anything else fancy is just adding extra sugars to coffee. The first thing is to save the life. So do what's necessary to save that life in your hands as based on your capabilities. You don't need to go to do everything at the same time. So it won't mean everything which I was explained. You main aim is just to save that life. So how do I save this life now? It's a rupture. I can get on bypass and take away and save the patient quickly. There's tamponade. I should relieve tamponade and do the surgery. There's an MI and to graft that vessel that have been damaged with a graft and excise the anterior tear. In the stroke, quickly gets on bypass and reestablish blood flow to the head and neck vessels. And if there's AI, replace the valve or repair the valve. So how do you achieve this? You must excise the anterior tear. You must ensure that you are reestablishing flow in the true lumen. You must, so when you're establishing a flow true lumen, you think about how do I obliterate the false lumen. Most times, once you establish flow in true lumen, the false lumen obliterate because there's no more flow in that lumen. So it clots off. And true lumen, which is now pressurized, will compress the false lumen. And over weeks and months, that false lumen from how big it was will just become flattened and disappear. And also, you must restore the competence of the aortic valve. So these are guidelines again on techniques for aortic surgery generally. For in a dissection, you can try to repair the valve, and the two repair we commonly do, if possible, in good hands, the remodeling and implantation techniques, which people call Yakub and David's. As we go further, we may understand them. So this just means you are preserving the native valve instead of replacing native valve. So they are valve sparing aortic surgeries. If you can perform them during dissection conditions, fine. But you must not do that if patient has dissection. These are better for aneurysms when you're planned and you're relaxed and you're in a good position. For chronic dissection, yes, possibly, but I won't advise it for acute dissection. But you must ensure you do an open distal anastomotics technique. And they recommend as a 2A accommodation for axillary artery to be first choice, but it's slower to get to. It's not very, if you are the patient is not doing very well, the femoral artery is the best, is the next fastest, or go central if it's safe to do so. You will not want to do a central cannulation if you have a pericardial collection, because there could be an impending rupture. Once you open the sternum, you will leave the pericardium rupture. Prefer to have cannulas in some vessels before you open the sternum. But if none of these and looks safe to do so, open the sternum, open the pericardium, and can cannulate centrally and go ahead with surgery. Just a few images for now. You can see there are two layers here. So this will be the intima here. This is your valve, this is intima, and this is the false lumen that have been created by blood flowing through here. Normally, this is one layer, but now that one layer is gone. You can see this one layer here, but now you have two layers. So blood flows through here and flows through here. And because blood flows through this false area, it compresses any vessel by the side, because the two lumens in the middle, but the first lumen is around these vessels here and can compress them and lead to symptoms they get. So to open the aorta, look for once you see the entry point, you know where it is, then you can excise that area of the aorta. And now you have a clean area, no entry tear there, and you can anastomose your Dacron graft, which you commonly use, to this end of the aorta, and you have replaced that aorta. So people commonly, which I would also commonly use a Teflon. Teflon is a strip of material, like a cloth, just to reinforce your suture line while suture. Because one thing in aortic dissection is that you suture a lot. And suture a lot, there are holes. There are holes bleed. And after surgery, 6 hours on bypass, you have coagulopathy from prolonged bypass time. The whole clotting profile patient is deranged, a lot of bleeding. If you use this Teflon, they help to prevent this bleeding, because they form a bit of a compress on this weakened tissue which you have after dissection. This look clean on picture. This look clean on picture. In reality, this will be bruised. You see it all looking dark red, black, and they're not very so they're not very not as sweet as this. But so you just make sure you deal with that. If you look here, this is a surgery done. This is a Bentile procedure. I just expose it, and there's a new valve here. You can see the valve leaflet. This is a mechanical valve leaflet. This is a mechanical Bentile procedure. It means you're replacing the root of that's within the valve, the root itself, and you're using this conduit up to the brachiocephalic artery up to the ascending aorta. And you're going to implant the coronary arteries, the left main coronary artery, this is the right coronary artery, and implanting them back on the graft itself. And this is a modified Bentle's procedure. This is the most common surgery you see for dissection in every gentleman's hand. It's just the valve is fine or not fine. In this case, the valve is fine, so the same valve is there, and just replace above the santular junction. So this is less extensive. This you can sometimes do the clamp on. So you put the clamp here, sort out the valve here. All here is fine, then suture the graft to this point here. After suturing the graft to this point here, then you can take clamp off, go on deep circulatory arrest for a few minutes, and suture it back here. And this is another modification whereby the valve is leaky. You want to avoid doing this, which is more extensive. You're going to add suture this back to this. You can put a new valve in the road and replace the valve, the ascending aorta above the valve, leaving the coronaries intact if the tear does not extend to the coronary ostia. Okay, the next topic we'll talk about quickly is the intramural hematoma. It just means the vasa performance ruptured the blood in the tunica media. And this is how you see it on CT scan. You see blood nicely here in this aorta, which is enlarged. You can compare this size to this size. So this patient actually has an aneurysm of the ascending aorta ab initio. And you can see this swelling, this area of darkness around here is blood. So it's swelling around the aorta. That's the hematoma, intramural hematoma. And this scan, which is non-contrast, you can see a bit of contrast is quite enhanced around it. So that shows that, yeah, there's some blood there. So that's the intramural hematoma. What predicts that there will be complications if you cannot control the blood pressure? This might be complicated. And if the size above 11 millimeters, then you think about procedure for this patient. If they're having effusions on both sides, then you think of impending rupture or endocardial ischemia, to treat them as a type A dissection. So same like type A dissection, urgent surgery is recommended, and blood pressure control is also recommended, class 1 indication. Pertinent ulcers is how you see the aorta. You see the aorta and just see these out patches everywhere in the aorta. Commonly in the arch, but these patients mostly we don't treat them surgically. We just give them medical management, blood pressure control, and follow them up with scans. However, if they now show features of an intramural hematoma or a dissection or having persistent pain, then you may need to re-image them and consider surgery. Patient with continued rupture, very rare. But if they have continued rupture and it's in the ascending aorta, surgery is recommended. If it's in the descending aorta, stenting is recommended. Traumatic aortic injury, we may not survive. If they do come to you, obviously surgery. If they're in the area of if the anatomy is suitable for stenting, then TIVA is preferred because it's faster and less. Then you don't stay on bypass forever. Now, to quickly do aortic aneurysms, this is enlargement of the aorta. Simple. Fusiform enlargement, circular enlargement, whatever type. The walls are all, they are true aneurysms and not false aneurysms. So they can involve just the differ. Now, the aorta grows in life as you grow older, the aorta grows, and these are normal sizes 0.9 millimeters in men and 0.7 in females. However, in patients with Marfan syndrome, it could be quite faster and go up to 1 millimeter per year in patients. Patients with Lois Diggs, even faster. There is a variant, and they can go as fast as 10 millimeter a year. So if aorta is above 40, then we say that aorta is enlarged, and you'll be on monitoring for life, though, because anytime the aorta is enlarged, it could rupture at any time. So according to guidelines, we have what we say is an indication to deal with these procedures. And these indications are based on if the patient is syndromic or non-syndromic. Syndromic means you either have Marfan syndrome, Lois-Dick syndrome, Turner syndrome, or familial conditions in the family, So if you have Marfan syndrome, the ward at this time is still 50. So if someone has Marfan syndrome, no valve problem, and its aorta is 50 millimeters, we offer them surgery. So in the American guidelines, this has gone down to 45 actually. So in the American guidelines that came out last year in 2020, last year or early this year, if your aorta is 45 and you can offer safe surgery, the Marfan patient, offer them surgery. Now they also say if your patient has Marfan's and his ascending aorta is 45 and he has risk factors. What are his risk factors? Hypertension, family history of dissection, or rapid growth, or coarctation. You should offer them surgery at a lower size. Now, if patient has a bicuspid aortic valve, we know that, as I said earlier, that bicuspid aortic valve are treated with aortic enlargement, aortic aneurysms. If they're 50, if the valve is fine, we replace the aorta. However, if the valve is stenotic or regurgitant, so if patient has severe aortic stenosis or severe aortic regurgitation, who requires surgery for his valve, if the aorta is 45, replace the aorta at 45, don't for 50. But recently, the thinking now is that these numbers are just figures. Yeah, we need to take them lower because surgery is now to be safer because these numbers were made because the risks of surgery must be less than the risks of the condition itself rupturing or leading to complications. So if surgery which is higher, they don't need to do surgery then. So that's why, because surgery is becoming safer, tend to be reducing the dimension size nowadays. Yeah. So they've done studies, several studies to show that this study done in the US by Mr. Efaridis and his colleagues there, they found that if the aneurysm is growing slowly, once it gets to, you see, this is the risk of complications, 5%, 6%, 7%. As it gets to 5.9 centimeter in size, it's exponentially increasing in size. That's kind of complication, which will be rupture, dissection, or whatever it is. And that's why that cutoff of 5.5 have been coming to place as the cutoff for any aneurysm. So once I get to 6, you need to quickly repair that aneurysm. And for Marfan patient also, they done a study to say, okay, Marfan patient actually, it even goes 4 times faster. The risk is higher 4 times. So that's why you need to replace patients with Marfan syndrome earlier than normal patients. So that's why in this patient, when you're taking history, you need to ask questions, look at the features of clinical examination of patient with Marfan, if he has a Marfan or syndromic, tall patient, arm span, bifid uvula, stuff like that. And if a patient has this condition, you need to put them on scans, you need to monitor them with scans. It could be yearly scans to see the growth of the aorta. In Europe, we use is 3 millimeter per year. So if the aorta grows more than 3 millimeter per year, that's a rapid growth, and we tend to offer them procedure because the aorta is growing in a rapid way, and we might need to treat them often. Some medications have been brought these days, beta blockers. They said if you start on beta blockers early, it has a protective, it's protective to reduce the increase in size of these aortas over time. So if a patient have indication for that, put on beta blockers, you just reduce the shear stress on the aorta and reduce aortic expansion. For coarctation, the most thing we do for coarctation is mostly if they are amenable, is stenting these days. That's what we prefer. However, if that's not possible, then they have a surgery. Quickly go through the last few slides. So this is the aorta. Surgically, we have zones of the aorta. These are the zones 0, 1, 2, 3, 4. These are a CT scan of aortic dissection. This is what we commonly see, just see one flap. You see this line, that's the flap. The 2 lumen is always the bigger lumen, so I don't know why, but because blood flows there preferentially because it's just flows there because of the tear. So you have blood in the first lumen and less blood in 2 lumen. So when you have, and 2 lumen supply the main vessels. So when you have blood in 2 lumen, the organs that the body supplies are reduced. However, in this scan, we have blood in both lumen quite glowing, but this is smaller than the first lumen. Just image now. So this is the standard procedure everyone has mostly done. If you look at the data, the section is called and place from this tubular junction here, like also with or without valve, and all the way to the arch. You don't do a flush osmosis like this. So you go under the arch here and replace it. Because most times in what we see, we'll find tear here and may find a tear around here. So that way we've excised the tear in the arch. I'll put our osmosis like a oblique osmosis all in this way. And most people do at night because dissections, I don't know why they come at night, they don't come in the day when you are ready. Now this is a pental, we've seen before. So a valve, put a valve there, replace the valve, replace the whole root with the graft conduits and the anastomose the coronaries. Then Professor Yakub, who worked in UK and Brompton, developed this procedure whereby initially he didn't deal with anything rude, but this for mostly for aneurysm, not dissection for aneurysms. You excise the, you make a tongue of the graft to go into the commissures or the sinuses and replace the coronary artery and just leave that alone. Then Tyron David in Toronto developed, instead of doing that, did this and did a tube graft that goes into the graft itself, into the root itself, and your valve lies within the tube graft. The tube graft ends on the root, so stabilizes the root, and you have this. So most people do this these days because you have root is stabilized and there's no more native tissue exposed that can enlarge over time. This is like when in the days they didn't have what we call an elephant trunk, we tend to do a kind of Carrel patch, take off this and put a graft off to the descending aorta there, and as the multi-aortic vessels. But with the advent of materials from the companies now, like we can have a branch graft that has 3 branches. We could what we call debranching. We could debranch the aortic vessels and leave this trunk like an elephant trunk in the descending aorta for future endovascular procedure, call it like a TIVA. Because now they have a landing zone. They could land any stent into this graft. So that avoids landing a stent on a weakened wall of the aorta. It's called an elephant trunk. This is actually a floating elephant trunk. It's floating because there's no stents in this trunk. And people have done many techniques. So people have tried to say, okay, you have an aneurysm on the aorta, cut to the aneurysm and put a suture it with Dacron. This doesn't work these days. So people try to put a wrap around the aorta, and if you wrap it that way, the aorta does not expand anymore. But these days, surgery is safe to do a replacement, just replace the aorta if you can. Now we're going towards more complex stuff. Now these are arch procedures. Now the arch was a difficult area in surgery because how do we take the blood away from the brain and put it back on? How do we achieve that? So there's been very quite complex. So we try to cool the body down to 18 degrees. At 18 degrees, you have like 35, 40 minutes. You can safely do surgery quickly. And you have to stitch quickly to make sure you get the head and neck vessels back. Otherwise, as you stay longer, the head just the risk of strokes is higher. And if there's no joy doing surgery, and patient cannot walk or is cannot wake up. It's just failure of care. So that was a big problem. But these days we have a lot of devices and a lot of techniques whereby we can monitor the brain first with cerebral oximetry. We can debranch, so we can take one vessel at a time. So take this one first, anastomose here. Blood is still flowing. We still leave this blood flowing through these vessels by putting tubes through them. So we supply what we call antegrade cerebral perfusion. So if you have an intact cycle of Willis in the brain and you supply blood to the left side, you should supply the right side of the brain. That's what we rely on. And we monitor this with devices on the skull to test if that's working properly. And we can take the one vessel out, anastomose it here, back on circulation. Next vessel, same thing. And next vessel, same thing. We can debranch the neck and the vessels easily while we're cooling down. Then we can now anastomose. Since the vessels are now away from the arch here, we can now anastomose quite near to us instead of going all the way here to anastomose, which is very difficult. And we can now deploy a stent with the graft has, we call it frozen elephant trunk, down into the descending aorta. All these are tied off. And we've done the surgery. Anything they don't need to do in the future, like here now, there's still a tear in the descending aorta. This aorta can still enlarge over time, but because they have this stent graft here, you can come in from the groin and land the stent into a true lumen and expand this in the future. So this is the evolution from the 80s when Hans Bost, who died last year sadly, developed the elephant trunk, all the way now we have beautiful stuff on shelf. We can do many things with these devices. This is a new device that just came out recently. They call it AMDS. I won't bore you with this. It's also a way you can stent the arch. So you can see this is a not a covered stent, a naked stent, but you can anastomose here at zone 0 where you can see. I think there's a 10 in the arch. You can put this stent. This stent expands and compresses. This is your first lumen down here, but up here is compressed. And when it's compressed like this, it seals off with time, clots off, and the first lumen does not exist anymore. And you can actually deploy stents here afterwards. So if you are tired or not tired, if you don't do any extensive surgery, cooling down too much, you can try to do this procedure. Deploy this in 10 minutes, switch around here in 15 minutes, you're done. And that what the device is meant to do. This is what called Dane. Just when you switch around the aorta, just be careful while you're switching around, you won't see again into the first lumen. So you've done your surgery, your anastomosis and your distal anastomosis, contrast in your first lumen in the arch or descending aorta of the Dane phenomenon. And that's what AMDS was meant to treat by putting the stent here to eliminate that Dane. Yeah, this is a CT scan of patient with a dissection. You can see blood here. You can see leak of blood here. You can see how the lumen is compressed. You can see how terrible looks like. You can see this descending aorta is all a mess there. Huge aneurysm, blood everywhere. And what you just need is just to get blood flowing in the right place. Once blood is flowing in the right place, in the right lumen, all this will disappear with time. I think this is the surgery we did for this patient actually. So this is a schematic diagram of the surgery that patient had. So I think this is almost my last slide. So aortic disease is we have them now. They're all around us. Most people will die if they don't come to hospital because of the the availability of conduits and graft and prosthesis, and because aortic surgery is now a subspecialty, a lot of experience in aortic surgery, a lot of interest in aortic surgery, we can offer patient surgery with improved outcomes compared to 20 years ago. Thank you for listening.
Thank you very much, Dr. Ben. Does anyone have any questions? If you have any questions, you're not able to unmute yourself, so just pop it up on the messages, on the message chat, on the chat, and we'll be able to answer it. Thanks very much, Dr. Ben. That was a very extensive and very detailed presentation. I know the time is not quite enough to go through everything, especially the aortic procedures part. It's a lot.
Yeah, it's quite extensive, but we'll see. Well, another time we can get on that topic to just describe procedures themselves.
Yes. Hopefully, so, this is just like a basic introduction to everything. I think later on we will do more specific topics and have more time to dissect it.
Okay.
Does anyone have any questions? I'm not seeing any questions. Okay, I'm going to put up the Okay, so someone has asked a question.
Okay.
Is there an alternative or second line drug for controlling blood pressure aside labetalol?
Yes. So if you have a dissection and go to support the patient, we prefer labetalol. Why? First, because it's intravenous. Patients with dissection are having surgery with knee by mouth, so if you can give any beta blockers, but intravenous. Now, if you use what people commonly use GTN infusion, which is quite very common, GTN infusion give. But GTN, yes, it reduces blood pressure, but it increases the shear stress of the rebound effect. Unlike labetalol, which doesn't do that. And the commonest drug we have is labetalol. Esmolol is short acting, so the beta blocker, so you have to give it quite often. But labetalol an infusion pump can last a bit longer. However, if you don't have it on shelf, fine. You have to use what you have and get a patient to theater. That's the main thing. Another question here is, so for intramural hematoma, question from Clinton O'Kenne, you treat like a type A dissection. So if you have an intramural hematoma that is expanding, so it's getting bigger in size from serial scans. Serial scans will be done at least in a week. So if you patient come today, you do a scan in 1 week, and it's bigger in size, or a patient has pain, or worsening pain, or persistent pain, or end organ dysfunction. So maybe is more drowsy, so maybe having head cerebral ischemia, or having abdominal pain, or the kidney function is deranged and worsening. You need to deal with that patient, and that's why we do surgery for them. Surgery we do for them is just ascending aorta replacement for most of the patients. If it extends into the arch and arch also enlarged and dilated, you must do an arch replacement. So all based on the extent of the enlargement of the area of the aorta. You might replace the whole of the aorta if need be.
Thank you, Dr. Ben. Any other questions? I've put up the feedback form on the chat, so please fill up the feedback form. Fill the feedback form and so that you can get your certificate of attendance. And just also as an announcement, the fourth session of this series will be taking place on Monday, 6 p.m. The advert middle page, so you can sign up for it. It's the second part of the cardiac physiology that we started on Monday. There's another question.
Yeah. Okay. So so the elephant trunk, it provides you to do this procedure as a stage 1, preparing you for the stage 2, which will be a stented procedure. Now, for the elephant trunk, if you suture your distal suture line on the aorta will be around zone 0, and this at zone. Pavement artery is very posterior. So if you're on the front of the patient, it's very posterior and deep in the chest. It's very hard to suture there. And when you suture there and there's any trouble, it bleeds. To get back there is difficult and it's a nightmare. So the elephant trunk has made it possible for us now to draw in zone 1 where the aorta is closer to us and deploy this stent down. So it makes it a bit easier for a previously difficult procedure. So that's the advantage of the elephant trunk over other straight grafts we had in the past. So it gives you a chance for a stage 2 procedure and make the procedure itself much, much easier than previously.
For a literature recommendation.
Well, everything is, there are many documents online. You can okay, I can drop my email. You can send me an email. I can find some sites to refer you to. Is that okay? And Ifemi?
Yes, that would be great. So yeah, I think I have your email address. If you
Okay, yes, you can just share the email with them, and
yes,
you send me an email. I can find sites and materials to share with you guys.
Yeah. Yeah, that's it. Okay, I think we are just in time actually. 1 minute left. If there are no other questions, thank you very much, Dr. Ben. This was
Thank you for the
very
opportunity.
very good and insightful. Don't forget to fill your feedback forms, guys. It's when you fill it, you'll be able to get a certificate of attendance, as I said. And don't forget to sign up for the session 4, which is on Monday. Thank you, everyone. Thank you, Dr. Ben, and see you
Thank
all
you.
hopefully. Thank you, guys.
Thank you.